Well, I'd now like to invite my panel up. We're going to be talking about behavioral health integration in obstetric settings, which is a great segue, I think, to Dr. Wisner's talk. And Dr. Wisner, thanks for level setting and giving us a lay of the land on the range of disorders and onset, and also the drug treatments. We appreciate you so much. You're an icon, and we're so grateful that you're here. So we also are going to invite Dr. Guille to join us via screen. She is having to join us from South Carolina. So we'll welcome her to the stage too. All right. Well, I'm going to start with introductions. And I'd like each of you to introduce yourselves. Jennifer, I think we'll start with you. We'll start with you, Jennifer. Tell us about your role at Blue Shield of California. And as I turn it over to you, I just want to also acknowledge the sponsorship from Blue Shield of California. We're so grateful for the premier sponsorship. Thank you.
Right. Can you guys hear me? I can't tell if this is on. Great. No, and we're happy that we could sponsor. So I'm Jennifer Christian-Herman. I'm a clinical psychologist, and I am at Blue Shield of California. I'm in a role as the Vice President of Clinical Strategy and Programs. And part of that is a focus on transforming behavioral health. And we've been doing a lot of work around integrated behavioral health in primary care and OB and other settings. So excited to share a little bit about that today.
Thank you for that.
Hi, my name is Florence Fee. I'm Executive Director of a patient advocacy nonprofit called NHMH, which stands for No Health Without Mental Health. We have been around for 17 years. We have a focused mission to advance, primarily through health policy at the federal level, to advance evidence-based, widespread use of evidence-based integrated care bidirectionally, so incorporating evidence-based mental health care into medical settings such as primary care, and also incorporating improved physical health care into specialty behavioral health settings such as community mental health clinics and psychiatric facilities.
Thank you for that. And we're grateful that you're here and also leading a work group on behavioral health integration nationally with lots of national mental health partners. You want to tell us just a little bit about that, and then we'll introduce Connie.
Right. There are two leading umbrella coalitions for behavioral health, which encompasses both mental health and substance use disorders, the Mental Health Liaison Group and the Coalition on Whole Health. They're based here in Washington, D.C., and they're made up of members, national organizations, medical and behavioral, that are represented in that organization. So the Mental Health Liaison Group is sort of the go-to organization for Capitol Hill congressional offices that have bills associated with mental health and where they want to go to the advocacy community and get support for a piece of legislation. We'll go to the Mental Health Liaison Group. We recently formed in June of 2024 a integration work group. We've had other work groups on parity, child adolescent mental health, workforce issues, telehealth, but we just added a bidirectional integrated care workforce of which I am one of the co-chairs. We also have a integration work group in the Coalition on Whole Health.
Thank you for your leadership there. We'll turn to Connie now, who's going to join us and do a brief introduction, and then we'll dig into integration. Connie.
Great. Good morning, everyone. Can you hear me okay?
We can hear you, and I should have said Dr. Guille. I hope you're feeling well and glad you're with us.
Thank you so much. And I'm sorry I couldn't be there in person today. I really appreciate being able to join via Zoom. My name is Dr. Connie Guille. I'm a reproductive psychiatrist at the Medical University of South Carolina. My work has been focused on the integration of behavioral health into obstetrics care, doing that in person and also using a lot of technology-based platforms to do that throughout the state of South Carolina. And yeah, happy to talk some more about what we do, but that's just me in a nutshell.
Thank you so much. And we're going to turn it back to each of you. If you can just tell us a little bit, we'll start with you, Florence, the history of the integration movement. And first, if you could tell us, what is the continuum? What does that look like? Behavioral health integration in an OB PCP office with screening, all the way up to collaborative care on the far right, in my mind. Do you mind sharing a little bit about that continuum and the history?
Sure. Okay. I thought it might be useful to get into the definitions and also to provide context for this discussion. There's a lot of oftentimes the terms chronic care model, collaborative care model, integrated care, team care. Those terms are used, and sometimes they're used incorrectly or they're used interchangeably when they're quite different. But they are all related, and that's what I wanted to explain. So to understand and place in context recent developments in healthcare and health policy, it's important to know the evolutions of these models of care. So the real foundational model that we're talking about here as a primary care initiative was a chronic care model, which was developed by Wagner et al. With Bodenheimer and Grumbach in the 1990s, a primary care initiative that was a new way of treating patients with chronic illness in primary care. And it became the framework for improving chronic illness care. What was different about the chronic care model was that it aimed to improve care at both the individual and population level. It is assumed that improvement in care experience requires incorporation of the patient, clinician, and system level interventions. So the chronic care model has 4 components: self-management support, clinical HIT, health information systems, development system redesign, and decision supports. So this, as I said, the chronic care model is really foundational. It has been the dominant model for the patient-centered medical home and achievement of the triple aim. So now I want to talk about the collaborative care model, which you've heard references to this morning. The collaborative care model is a specific type of integrated behavioral and physical care, and it was derived from the chronic care model. So again, the collaborative care model derived from the chronic care model. So collaborative care and other evidence-based integrated care models, such as the PCBH, patient-centered behavioral health model, they aim to improve access to evidence-based mental health care for primary care patients. So again, chronic care model aims to improve care for chronic illness. The collaborative care model aims to improve access to evidence-based mental health care and primary care for primary care patients. So collaborative care has 4 important components. It's team-driven, and by team we mean interdisciplinary team. It's population focused, just as the chronic care model is. It's measurement guided, very important. Patients are monitored for progress and improvement and outcomes. And then fourthly, it's evidence-based. So a limitation of the collaborative care model is that it's not a one-size-fits-all. It has to be adapted to the particular practice or health system and also to the different patient populations. So, for example, in the OBGYN context, collaborative care has, and the references already been made to, has to be adapted to the needs of women in OBGYN clinics. But collaborative care can be maintained across those different settings.
And then tell us just quickly about the other end of the spectrum, and then we'll move to Jennifer, Dr. Herman. Behavioral health screening in OB clinics and referral, for example, on the other end of the spectrum.
Okay, you mean as far as what it looks like in the clinic?
Yeah, and I almost answered that question for myself by describing that, didn't I? So Florence, hold that thought, and then we'll come back to you, and you can reflect on some more in just a moment. But Dr. Christian-Herman, can you tell us a little bit about how payers are starting to think about behavioral health integration, and why is that important?
Sure. So I can speak to Blue Shield as a payer, but I think some other payers too. I think there's a recognition of certainly of the broad evidence base behind integrated behavioral health models. And also as we all are struggling to provide access to care, really thinking about what is that ecosystem of care. It certainly helps to break down stigma. And if you can have universal screening, but you have to have something to do if you get the yes when you screen. So we think it's really a big part of how we all collectively solve for access and break down stigma. What we have found, and actually I did a fellowship with Inseparable, I see Inseparable folks there, really looking at that. I mean, there's long history and a lot of evidence around these models, but they have not been brought to scale, even in primary care, much less in OB. And so one thing that we have been tackling is how do we bring payers together? What we hear from providers and even large provider groups is that it's just too difficult if each payer has different pay rates, different processes, that it's almost not worth doing it, or they're going to do it and they're just not even going to bill for it. And then it doesn't become sustainable. So we have brought together a multi-payer collaborative to think about how do we do this together? Sort of you can, if you want to go fast, go alone. If you want to go far, go together. We need to go far with this. And so how can we all partner together and really think about the whole village, which payers are an important part of that, but certainly providers and others, and how do we come together with policy to actually bring this to scale?
Great. Thank you so much. And I think the fragmentation in our health delivery system is certainly a big barrier to scaling much of anything, but behavioral health integration in particular. So on that opposite end of the continuum with COCM, or collaborative care as it's called, the other end is screening and referral, right? And we need a place to send folks, et cetera. But one of the pioneers in this space is actually Dr. Guille, and we're so happy that you're with us to tell us about a couple of your research studies and how you've been working on behavioral health integration. I also just want to call out in the app, Whova app, all of us in the room and those online, of course, you have access to these studies that were published in Health Affairs in the Perinatal Mental Health edition. Thank you to the funders for that edition of Health Affairs. Dr. Guille, I'll turn it over to you to tell us a little bit about how you've started this work and what does it look like.
Sure. Thanks, Joy. And thanks for including that article in the app, because I think it is a good summary of a culmination of work. And, as it's already been highlighted, we have a really robust evidence base for things like screening, brief intervention, and referral to treatment, and collaborative care and integrated care models. But really the goal and trick is actually how do you get this into practice? And so being in the research space and also the clinical space, we started doing qualitative research with providers and patients just around this issue, and really appreciating on a very deep level the patient, provider, and healthcare system barriers that get in the way of successful screening and referral to treatment. And by doing that, came up with a program that we call Listening to Women and Pregnant and Postpartum People, which really attempts to overcome a lot of the stigma that patients experience by asking these behavioral health questions, everything from substance use, intimate partner violence, social determinants of health, and mood and anxiety questions via text message. So if you were to come into a prenatal care practice, you would get enrolled into this system in a way in which we sort of destigmatize these illnesses, saying that, look, these are very common. 1 in 5 women will experience these. We're going to monitor you for these symptoms in the same way that we're going to monitor your weight and your blood pressure. And if that's okay with you, we'll send you this survey via text message. You can complete that while you're waiting for your provider. A care coordinator would review these, and also your provider would be aware of this. So individuals complete that screen on their phone that is immediately gives them automated feedback about what that screening actually means, and if a care coordinator would be reaching out about that, and also alerts a care coordinator if someone is screening positive for any of these conditions, and that person is reaching out by phone and really doing that good brief assessment intervention, which we use shared decision making and motivational interviewing to get people to treatment. So that is the program that we designed really with patient and provider input. And then we've tested it in a few different ways. One is in a large randomized controlled trial with about 415 people, and essentially showed that if you were enrolled in that Listening to Women intervention, in comparison to what we called usual care, which is actually really the standard of care, where we have screenings that are done in OBGYN practices. It's integrated in the EHR. The referrals are actually co-located providers within that clinic. So in comparison to that sort of gold standard, using Listening to Women, we found that participants were 3 times more likely to screen positive with that Listening to Women intervention. 3 times more likely, to be screened just at all. 3 times more likely to screen positive for those same screening questions that they were receiving in person. 4.5 times more likely to be referred to treatment, and about 5.7 times more likely to actually attend treatment. We also looked at this through sort of a health disparities lens, and identifying that among Black non-Hispanic women had similar outcomes in the Listening to Women intervention, as well as in rural and non-rural areas. So we're continuing to use this to test it on a larger scale as well.
Thank you, Dr. Gill. I heard a few enablers that I think we can tease through with you just a bit. Tell us just a little bit more. Dr. Christian-Herman talked about how we say we need to medicalize and communitize access to care, but on the medicalize access to care of maternal mental health disorders, we're talking about starting with screening and how having your provider tell you this is the number one complication of pregnancy can help reduce stigma, help educate patients. But Connie, I think your study was really fascinating because you found, as you alluded to, that face-to-face screening may not be as effective, and perhaps that has an element of stigma. Can you help us unpack again the technology? And I think you started to use that technology during COVID, so it was sort of a surprise. You may not have gone there. Can you tell us just a little bit more about why you think that's working so well?
Yeah, and we were sort of surprised too when we first saw some of our findings. And so that led us back to patients to do some more qualitative research. In particular, we were interested in peripartum Black individuals and how their experience was using this text message system versus not. And what they really said was that answering these questions via text felt as if they were not going to be judged. They felt like it overcame a lot of the stigma. They felt more comfortable essentially endorsing these items, as opposed to when you're sitting face to face with a healthcare provider. And I think many of us feel that way. You know, it's sort of this anticipation that you're going to be judged no matter what. And so that seemed to help overcome that. Where they really appreciated the technology was actually having a phone conversation with the care coordinator, because they could sort of warm up to a conversation and figure out if they were going to trust this person or not. And then sort of in a conversation, be able to discuss these issues more comfortably. And again, just because someone was not sitting in the room looking at them, they just felt like it was easier to do this by text and phone as opposed to face to face.
That's great. And we also know, of course, the travel time to offices and making appointments and all of those things can be barriers. Thank you for unpacking that a bit. I did want to unpack the care coordinator piece just a bit more, and also allude to a pilot that we're running with Common Spirit Health to expand the capacity of an OBGYN or even a midwife's office. Can you tell us a little bit about how that's structured? What does the care coordinator look like? How much time do they spend with patients? Are you billing those hours? Those types of things, Connie, would be helpful to hear about.
Sure. So we initially went with a care coordinator that had at least a master's in clinical social work. And we did that because we know they have a really great background in assessment and referral for mental health conditions. They also are really great at identifying social terms of health and connecting people to resources. So that's who we went with. I think that there are a lot of different people that could potentially be in that role, but that seemed important when we were first testing this. That person we have a few people that are in this role right now. One of them is credentialed in our system to be able to bill for services and can bill for things like screening and brief intervention. Within our state, we have some billing codes for the peripartum population in particular. There's also some other billing codes that they can use that are just for chronic care management. So they have a couple options for billing and sustainability with that.
Great. And I think that's a key opportunity to think about billing and reimbursement, of course, in OBGYN settings. We're going to unpack that on a panel in a bit. So thank you for raising that. Dr. Gill, I do, though, want you to share a little bit about the screening rate reimbursement, because this also, I believe, is a part of the success you're seeing in your program.
Sure. So in our state, we actually have not adopted collaborative care codes until recently. And so I think that this was sort of an attempt to have some of these things like screening and referral reimbursed. So a screening measure for an OBGYN or in an OBGYN practice is about $24 per screen. And then a brief intervention is about $46 reimbursement for an actual brief intervention and referral to treatment. So it really does support the work. It takes about 5 minutes for a care coordinator to review the screening information, look in the EHR, see what's going on with that person, and then reaching out to them. Phone conversations length is 5 to 10 minutes. If it's a little bit more complicated, maybe a little bit longer, but on average, 5 to 10 minutes. And really, with that time, the reimbursement is adequate.
Connie, we will unpack reimbursement on a reimbursement panel in just a bit, but wanted you to be able to share that. So Connie, we're going to keep it with you and want to hear more about screening. We all know it's a challenge to screen for maternal mental health disorders in and of themselves, and screen for bipolar disorder before prescribing, and the range of maternal mental health disorders for that matter. But you've also in your study started to screen or are screening for substance use disorder and also intimate personal violence. Can you talk a little bit about how that's going and why? And I think actually Dr. Wisner teed up the why, particularly with intimate personal violence very well.
Yeah, so I think we know that all of the, behavioral health, mental health, it's not just about one condition, and conditions are often highly comorbid in terms of mental health and substance use, and we need to be addressing them all together. I think some of the work that we've seen is that when we screen people for depression, and then we also evaluate them, for depression, we also pick up a lot of substance use, and so it's often comorbid, it's hanging together. If we don't identify one or the other, we're not actually getting people to appropriate treatment and appropriate care. So we thought that was really important. And I'm so sorry I wasn't able to be there for Dr. Wisner's talk. I'm sure it was fantastic. And she probably shared some data on intimate partner violence, which is often, it's actually higher rates in pregnancy and postpartum. There's been some really great studies looking at homicide rates in pregnancy and postpartum. And that's not something that we typically include in our maternal mortality data. And so it often is not recognized, but homicide during this period is actually incredibly high. A lot of those homicides involve an intimate partner, and there are really significant racial disparities in who is dying, with Black women being very significantly likely to be dying in result of homicide during pregnancy and the postpartum period. So being able to just screen for and ask people if they are feeling safe in their environment, feeling safe with their own partner, and just asking a few of those questions via screening, and then being able to get to a person that can talk about that more broadly and often be able to implement some of the just safety things that we want people to have readily available to them, and such things as securing guns in the homes, making sure you have a go bag, you have a plan if things get out of control, are sort of the interventions that we're putting into place.
Thank you for that. And I think folks are going to be very interested in unpacking the paper that's in the app. I just want to applaud you before we wrap up with some final question for the whole panel. For the work that you're doing, you really implemented the clinical practice guidelines by the American College of Obstetrics and Gynecology, and then some, Dr. Gill. Just thank you for your pioneering leadership in this space. And we will continue to learn from you. I'm going to ask the panel to give us one final thought on what you want to leave with the audience relative to behavioral health integration. And I'm going to actually take the liberty of addressing this first, is that it takes capacity to do this in an obstetric setting and a primary care setting. We know that, right? We can't ask OBs to do this without capacity and reimbursement. One of the things we're really excited about investigating is whether a community health worker can be and should be embedded in obstetric settings to support screening, brief intervention, and referral. And thank you to the funders in the room, at least one of you I see now, for investing in that work. And our hypothesis is that it will give OBs the capacity they need to do this important work, including the care coordination. There are also roles that insurers can play with regard to care coordination as well. I'm going to turn it to you, Florence, to give a final thought on something you want to leave the audience with.
Well, I would say that, the two we've been talking a lot about OBGYN, which is many women in pregnant women and go to the OBGYN clinics as their primary care. And I think that, the two main goals we're trying to address here is expanding access to evidence-based behavioral health care, as Dr. Guille said, encompassing both mental health and substance use. So expanding access to evidence-based mental health care and also addressing the chronic illness epidemic in this country and treating comorbid chronic medical and behavioral health issues together. We have chronic medical and behavioral health conditions are rampant in this country. 60% of Americans live with a chronic condition, and 42% of Americans have multiple chronic conditions. We spent $5 trillion on healthcare in 2023, and 90% of that was spent on treating patients with one or more chronic conditions. 20% of Americans suffer, and this is probably a conservative estimate, 20% of Americans suffer from a mental illness. That's 50 to 55 million people. One half of them get no mental health care at all. That's 25 million people. So, this is 30 years after the chronic care model was created, 15 years after the collaborative care model. And just to follow up on Dr. Gill's comment, Dr. Wayne Caton, who is the creator of the collaborative care model, or COCM as you referred to, was a mentor to our nonprofit for 4 years. And he was the lead author on a study, a randomized controlled trial called the DAWN study, Depression Assistance for Women Now. I urge you to Google that. It goes step by step how depression collaborative care was implemented in 2 university affiliated and county public health OBGYN clinics, and the results and how it actually step by step took
We'll
place.
add that study to the app. Thank you for reminding us about the Dawn study. Dr. Christian-Herman.
All right, so I would challenge other payers in the room or online to really talk with your providers. I think some barriers that we think are pretty common are how do you make it easy in terms of administrative simplification of claims, of all those things, make it clear. How do you provide technical assistance and even financial assistance for the startup of these integrated models, because they should be sustainable once they're up and running, but it takes a lot of work, a lot of change management, and that can be a barrier. Think about how you're paying. If you have a capitated model, you need to be paying on top of that capitation and incentivizing and making it feasible for providers to do this. So I would challenge payers to think about all those things and think about how you can be a partner in this and not a barrier, as so often payers are seeing.
Thank you. I think we ought to actually have a call to action, official call to action for payers around this. Dr. Christian-Herman, thank you for that, planting that seed. And then Connie, Dr. Guille, would you like to leave us with the final thought?
I'm so excited to have this group of people together. I think that different perspectives on this is incredibly important to move our evidence base actually into practice. I really appreciate the prior comments around that is the last step. We know what needs to happen to improve maternal health. It's all in how do we actually make it happen and make care delivery appropriate and meet individuals' needs. So thanks so much for bringing this group together.
Thank you, Dr. Guille, and thank you to our panel today.